We're now going to switch gears and talk about aggressive lymphoma. And it is my pleasure to introduce Dr. Cassandra Duarte. She is our most recent faculty recruit, and we are very proud of our fellow. She used to be the chief fellow here, and then we're very fortunate she decided to stay on. So she's going to be discussing all the highlights around aggressive lymphoma. Dr. Duarte specializes in all kinds of lymphomas, especially PTLD, CNS lymphomas, and also all the rare lymphomas. So stay tuned. There's much more that's coming from Dr. Duarte in the coming years, but today she'll be focusing on aggressive lymphomas.
Okay, thanks for having me. My name is Cassandra Duarte. None of my disclosures are relevant to the topic I'm talking about today, but they're up there for you. And so just because I am a new faculty member, I figured I'd give you some background on what I see and treat. That way, if you are from the community, feel free to send over any patients, but I see B-cell lymphomas, specializing in post-transplant lymphomas and primary CNS lymphoma. We have trials in both of those disease states, and then all other aggressive lymphomas. I also see patients with Hodgkin. And then I take care of our rare blood cancer program, so things like systemic mastocytosis, for which we have trials opening, hairy cell, Castleman's, and histiocyte disorders. We won't talk about any of those during this talk. In terms of our learning objectives, my hope is that at the end of this, you all can describe novel treatment regimens for elderly or unfit patients with DLBCL, talk about alternative induction strategies for patients with primary CNS lymphoma, and also discuss novel consolidation and maintenance strategies for primary CNS lymphoma. So here's a bit of an outline of where we're going. You'll see that a lot of the topics I'm talking about are relevant to the types of lymphoma that I care for. And so that's what I've decided to focus on for today's talk. So the first topic that we'll talk about is the phase 2 study on a regimen called POLA-R-GLOW. This was perhaps the most impressive thing to me in the aggressive lymphoma space that was presented at ASH this year. So the reason why I think this is so impressive is that we know patients who are fit can do very well with our chemotherapy. However, patients that are older, frail, unfit because of other medical conditions typically have a much lower response rate to traditional R chemotherapy. And so this patient population really has an unmet need in terms of frontline therapy for DLBCL. So in the R-POLA-GLOW study, patients were enrolled if they were untreated with a diffuse large B-cell lymphoma diagnosis at age 60 or older and were ineligible for traditional full-dose R-CHOP chemotherapy. Patients were allowed to have a steroid debulking pre-phase, and then for 6 cycles, they were inpatient, and they received step-up dosing in cycle 1 of obin, polatuzumab, and then glofitamab. And then for cycles 2 through 6, they received rituximab, polatuzumab, and glofitamab, and then continued on for cycles 7 through 12 with glofitamab monotherapy. And you can see the endpoint they were looking at was 1-year PFS rate. In terms of the patient characteristics, you can see here that the median age for patients on the study was 80 years, and almost 20% of the patients were older than age 85, which is pretty impressive to me. Otherwise, the rest of the characteristics were very much in line with what we expect for an aggressive lymphoma study. So 60% with advanced stage disease, 60% with the high IPI score, and elevated LDH. And then you can see here that at least about a third of patients had an ECOG of 2. In terms of figuring out if patients were fit or not, they used a couple of different tools. And so they had this simplified geriatric assessment. Just as a reminder for those of you that maybe don't think about these things clinically, they looked at ADLs, so people's ability to take care of themselves, so bathing, dressing, going to the bathroom, etc. IADLs, so independent activities of daily living, can they take care of themselves with shopping, managing, their household? And then the SIRS-G, which is a cumulative illness rating scale for geriatric patients. And so an impressive almost 92% of patients in this trial were considered medically unfit or frail. And so I think this is a very good example of a unfit older patient population in this study. We'll save the punchline for the end in terms of outcomes, but looking at treatment adherence and AEs, 80% of patients were able to finish their treatment. And then in terms of the significant AEs, one thing to point out, peripheral neuropathy, we know that's common with polatuzumab, Neutropenia was the only finding with grade 4, and then pneumonia had a grade 5 outcomes. In terms of the IEC toxicities, there were no deaths that were attributable to either CRS or ICANS. And you can see here that rates of CRS are about 30% in the patient population, with 4% ICANS, with most of these events happening for CRS with cycle 1, which is totally expected. For ICANS, I thought it was a little bit surprising that we had a patient experience it in cycle 1, and then 3 patients experiencing it after cycle 9, so 10, 11, and 12. That was a bit unusual to me, and so I would love to see more data on what they think was happening here, whether patients were relapsing, or remember this is a very elderly patient population, so were other things going on affecting their ICE scoring. In terms of infection, there were 3 known deaths, 1 due to COVID, RSV, and then 1 unknown. Patients did receive supportive care with GCSF and anti-infective prophylaxis. There was no commentary on IVIG usage. We know that this can help prevent infections, and so I'd recommend if you're going with this strategy to use IVIG. And I think one thing that explains the increased rate of infections in cycle 1 is that patients did get obinutuzumab as part of their step-up dosing for their glofitamab, and so just to be aware of that. Okay, so now to the most impressive part of the study, the outcomes. You can see here that the overall response rate to me was extremely impressive for a regimen that had no traditional cytotoxic chemotherapy. So POLA is an ADC, but there's no anthracycline, there's no vinca alkaloid in this regimen. And 90% of patients achieved an overall response rate, with 81% being a complete metabolic remission after 12 cycles of therapy. The 1-year progression-free survival was almost 85%, with a 1-year overall survival of 90%. And just as a reminder, the average age was 80 years old, with 20% of patients being older than 85. So I think this is really impressive data. So my conclusions for this study: it's an effective strategy for older individuals with very manageable toxicity. It's anthracycline-free, so great for our older patients who maybe have had other treatments for other cancers in the past. And you can see some late CMR conversions after cycle 6. So clearly, in my mind, the glofitamab maintenance is key to helping patients achieve a CR. Okay, the next thing we'll talk about is the battle of the bispecifics, is what I called it. I know that we're not supposed to do cross-trial comparison, but I think it's only natural when we have studies that are designed very similarly. So there are 2 studies presented looking at bispecifics in elderly, unfit, newly diagnosed DLBCL patients in the frontline setting. One looking at Mosun and one looking at epcoritamab. And so we'll walk through and sort of compare both of these studies. So for both studies, for the Mosun arm, in cycle 1, they got their ramp-up dosing. They continued on for a total of 17 cycles, 21 days for each cycle. And for epcoritamab, they had weekly dosing for cycles 1 through 3, and then every 4-week dosing for cycles 4 through 12. The inclusion-exclusion criteria were similar for both studies, so untreated diffuse large B-cell lymphoma, double-hit lymphoma. They accepted patients with an ECOG of 0 to 2, and both trials enrolled patients who were either 80 years old or older, or if they were younger with a comorbid disease. And so the differences in the IA criteria: patients on the mosunetuzumab study could have been 65 to 79 who were ineligible for frontline chemo, or in EPCO, they could have been 75 or older with a comorbid condition. Interestingly, they had to have an ICE score of at least 8, and then they also accepted grade 3B follicular lymphoma. So if you look at the 2 study populations, the epcoritamab study was larger at 66 patients compared to 49. You can see that the median age was the same between both studies, and both studies had patients at 81% for age 80 or older. One thing to point out is that the EPCO study did have more patients with an ABC subtype, which we know responds worse to traditional chemotherapy, and so I think it's important to acknowledge that. And then for the EPCO study, we also had more patients with a higher IPI score and more advanced stage disease. And so I'd extrapolate that to considering that the patient population in our EPCO study was a bit sicker than the Mosun population. So looking at the Mosun outcomes, you can see here that with the follow-up time of about 12.5 months, the median PFS and OS were not reached for the study. And for EPCO, we had a longer follow-up time, so 16 months for PFS, 18 months for OS. You can see here that the median PFS was 14.4 months, and the overall survival was not reached in this study as well. In terms of toxicities for CRS and ICANS, EPCO did have higher rates of CRS and ICANS. Infection rates were pretty similar between the two. Then in terms of overall response rate, you can see that there's a higher CR rate in patients who got epcoritamab, 73% versus almost 60% with Mosun, but had similar ORRs in general. So I think in this battle of these two studies, the EPCO study had a larger patient population, sicker population, longer follow-up time. Mosun had less CRS and ICANS, but EPCO did have a higher CR rate. And so I think if you're capable of monitoring for things like CRS and ICANS, you have an inpatient program, then I would consider epcoritamab for my patients. But if I was a community provider, no access to an inpatient setting, I think mosunetuzumab would probably be an easier option for those patients. And then one novel therapy I'll just bring up, we'll go through quickly. So there's a BCL6 degrader that was presented. So we know that BCL6 is an important oncogenic protein in patients with lymphomas. And so this was a phase 1/1b study that looked at this compound. And so patients could have had relapsed or refractory diffuse large B-cell lymphoma, 2 or more prior regimens, or relapsed refractory follicular lymphoma. They got BID or QD dosing. And of course, the primary objective was to evaluate safety and tolerability, and then secondary to look at preliminary efficacy. And so I think the important thing here in this study is that this is a very heavily pretreated patient population. So 2/3 of patients had 4 or more lines of therapy, with a median line of therapy of 5 for DLBCL patients and 4 for follicular patients. And 2/3 of patients were refractory to their prior line of therapy. In terms of side effects, and with it being a novel compound, the two that caught my eye were arthralgias and peripheral neuropathy. This was the reason why patients had discontinued for treatment-related adverse events. So just something to keep in mind, especially if we're considering combining this with other traditional agents like Pola or Vinca. And so I think that the data was perhaps a bit more impressive in our follicular lymphoma patient population, with 80% of patients in that arm achieving an overall response rate versus only 54% with diffuse large B-cell lymphoma. And I don't think that this will probably change our management significantly for diffuse large B-cell lymphoma. Only 7% of patients were able to achieve a CR, but I'm interested to see where this goes, especially for our follicular patients. Okay, so now we'll skip to some primary CNS trials and then wrap up with some trials to watch. So at least here at the University of Colorado, our standard for patients with primary CNS lymphoma is R-MPV. They get 5 cycles of therapy. If they're in a complete remission or a very good partial remission, we then take them to an auto transplant if they're eligible. I think primary CNS lymphoma is a really interesting area to practice in. The 5-year overall survival rate is roughly around 30%. And so obviously a stark difference compared to our diffuse large B-cell lymphoma patients who can do very well with frontline therapy. And because most patients with primary CNS lymphoma get diagnosed at an older age, I think it's really important for us to be thoughtful about how we design future trials to help this patient population achieve the best results possible. So we'll walk through some induction strategies, maintenance strategies, and consolidation strategies that were presented. So this is a study looking at zanubrutinib, Rtux, and high-dose methotrexate. So patients got 5 cycles of ZRM if they were in a complete remission. They then went on to an auto transplant. If not, they got 6 cycles of the therapy and then continued with Zanu maintenance. If the patient was not eligible for methotrexate, then they received Temodar instead. You can see here for patient characteristics, median age was 60, 60% had an ECOG of 2 or higher, and most patients were non-GCB subtype. In terms of the response data, you can see here, very good overall response rate, almost 90% of patients achieving a CR with CRM. And then you can see up here the PFS and OS. So 2-year PFS at about 83% and OS about 95%. And so I think this is a very reasonable treatment option for patients. There were no treatment-related deaths and only 1 episode of febrile neutropenia, and then no significant treatment-related adverse events for the Zanu, so AFib or major bleeding. They didn't present any data on the Temodar patients, and I'd love to see that because obviously patients that are older with maybe chronic kidney disease are not eligible for methotrexate. And my question is, if so many people were in a complete remission, why didn't more patients proceed to auto transplant? There are only 4 that ended up going down that route, and the data were not provided for that reason. So another study looked at RMPV with either the addition of lenalidomide or ibrutinib. And so patients were randomized either to arm A or arm B, with the dosing given there for len or ibrutinib. These patients, it was a French study, so they were randomized, they got 4 cycles of therapy, and then if they were in a complete remission, got 2 doses of Rituxan and cytarabine for consolidation, then proceeded to an auto transplant. So you can see here that the 2 arms were somewhat balanced between len and ibrutinib. I will point out that there's a lower KPS score, so lower performance status in the ibrutinib arm, but otherwise things look pretty similar between the 2. In terms of this flowchart, it's kind of busy. The one thing that I wanted to highlight was just the number of patients that were able to achieve an auto in both arms. So in the lenalidomide arm, only 77% of patients were able to achieve an auto versus the ibrutinib arm. 87% of people were able to get to that point. So something that's important to take into account. And then in terms of their primary objective for response at the end of induction, you can see here that the overall response rate was superior in the ibrutinib arm. And this was despite higher rates of dose reductions with ibrutinib. So 68% of patients in the ibrutinib arm had a dose reduction, whereas only 52% of patients in the len arm had a dose reduction. And so even with needing dose reductions, they still had better outcomes and more patients made it to transplant. In terms of adverse events, I'd say it was all very similar to what we expect for ibrutinib or for lenalidomide. So, an episode of a thromboembolic event with len, an episode of a subdural hematoma with ibrutinib, and then otherwise I would say the infectious risk was pretty similar between the 2. And then obviously the cytopenias, which we are well versed at managing. Okay, so to flip over to maintenance strategies, obviously maybe not every patient's eligible for an auto transplant. And so we have to pivot to use different maintenance strategies. These are not actually presentations, but just abstracts that were presented, but wanted to highlight them. This was a small study looking at zanubrutinib maintenance in patients with primary CNS lymphoma achieving a CR. And so they got 8 cycles of a methotrexate-based induction regimen. And if they were in a CR by PET and MRI, they were then put on zanubrutinib for 1 year. There were 7 patients, 7 of them were older than age 65. And you can see here that they had very good 12-month PFS and OS rates with 100% overall survival rate at the 1-year mark. A second study out of UCSF looked at low-dose lenalidomide in patients that were ineligible for an auto transplant. So they had 39 patients. In terms of transplant ineligibility, the reasons were about 2/3 of patients were older than 75. 18% it was due to their performance status, and then another 18% declined in auto. They had a much longer follow-up time, so 6 years. And you can see here that the median PFS and OS are quite good, so an OS of 5.4 years, and 60% of patients at this time point had not relapsed when the data were presented. So in terms of consolidation, there was one study, phase 1B, looking at nivolumab consolidation in patients that were ineligible for an auto. And so these patients got 3 cycles of a methotrexate-containing regimen, and then went on to receive 6 cycles of nivolumab consolidation. Again, small study, 14 patients, median age of 72 years. You can see the breakdown of therapies that were offered there. The overall response rate was 86%, with a CR rate of almost 80%, with a median follow-up of about 33 months. PFS and OS were not reached. Then the last study that I'll talk about, this was a retrospective study looking at the use of bispecific antibodies for patients with primary and secondary CNS lymphoma out of France and Belgium. You can see here that secondary CNS lymphoma is much more represented as opposed to primary CNS lymphoma, only 4 patients. Patients had exposure to both epcoritamab and glofitamab. You can see here that the rates of monotherapy were quite low, so 23% versus 10%. So, hard to say what's doing the lifting there, the other chemo or other agent that they're on, or the bispecific. You can see the overall response rate was about 66%, with a CR rate of about 36% for the total population, and then a CR rate of 25% for monotherapy with the bispecific. And then just some trials to watch. So things that were presented at ASH. So Dr. Voorhees out of OSU is looking at a study of epcoritamab and relapsed or refractory PTLD. Dr. Aperla has 2 trials out of Huntsman that I'm interested to see how those go. So ibrutinib in relapsed or refractory primary CNS lymphoma, and then Lonca and Rtux after SRS and CNS lymphomas. We have our own trial here, a CD19 by 22 CAR T-cell therapy in relapsed or refractory primary CNS lymphoma. That trial is open, so if you have a patient that's relapsed or refractory, we would love to see them. And then the Carolyn study, looking at lysosceles consolidation in primary CNS lymphoma over auto transplant. And I would say my presentation is done there. But just last week, there's a big update in patients with primary CNS lymphoma. So Dr. Nyack out of Dana-Farber had run a phase 1 study of axi-cel in relapsed or refractory primary CNS lymphoma, 13 patients. And based on this study, the FDA removed the restriction of axi-cel for primary CNS lymphoma. I will say that there are very high rates of neurotoxicity, so 85%, with 31% having grade 3 neurotox. There's early steroid use for ICANS, but no specific prophylaxis used. And so this is now the only CAR that's approved in primary CNS lymphoma. Thank you. And that's my email address there if you need to reach out to me.